Are we good? Okay, no disclosures. Very quickly, a 70-year-old lady, retired nurse, presented with right-sided weakness, speech deficits, and on exam, right arm and leg was 0 out of 5 on presentation, with sensory loss to her right leg. This is her MRI, and as you can see, there's multiple areas of focal edema, consistent with thromboembolic phenomenon and a watershed area of edema. So we spent about an hour talking about appropriate use criteria. Show of hands, who would do an echo here? Okay, so TE or TEE versus transthoracic. TEE, anyone? Transthoracic? Okay, so something else? Maybe not. So my wife was the one actually who happened to be reading echo that day. And she was sitting with a medical student. She says, well, you know, neurosciences, they're the #2 consumer of echoes outside of cardiac. And typically, we don't see anything. So up comes the echo, and it's like, whoops. So question is, what is your diagnosis? So is it a thrombus? Is it apical hypertrophy? Is it hypoeosinophilic syndrome? Is it a primary cardiac tumor or a secondary cardiac tumor? So I will let you look at that for another 10 seconds and choose your answer. Who? Okay. Next steps. Contrast echo, cardiac CT, cardiac MR, FDG PET, or a mass resection. Okay, remember the lady's just had a stroke, still has some deficits, so cardiac surgeons typically don't like taking them right away. Nevertheless, who would choose number 1? And another couple of people. Cardiac CT, anyone? Cardiac MR? More people. FDG PET? One hand. And a mass resection? Referral? Okay, the rest, not quite sure. Okay, so before I show the MRI, which is basically what ended up happening, I just want to direct your attention to the center of this mass. Notice the hypoechoic center in several spots. And it becomes relevant once we start doing, because this is a case actually illustrating the complementary roles of multimodality imaging. Qualifier, I do not read MRI or PET, but the MRI, you can see. Interestingly, the apex is hypokinetic, if you would agree with me, which raises the possibility of maybe this is thrombus. Could it be? So, and this is the multi-slice reconstruction of the MRI. But what we do, and those of us who do perfusion echo would find it relatively easy to interpret, is we can do perfusion MRI. And so this is a first pass gadolinium injection. And white basically represents blood. And as you can see, right at the very beginning, the myocardium is dark. Then it starts filling in. But look at the mass as well. Right at the very beginning, you've got a black mass, and it fills in. What does that say? That says that the mass actually is being perfused. So typically, thrombi are not perfused, and tissue would be perfused. So seeing as we've given gadolinium, what can we do? Well, late gadolinium enhancement. So basically, what we're looking at is in masses, for example, like angiosarcomas of the heart, typically you will have a hyper-enhancing ring with a necrotic center. So you're looking for late gadolinium enhancement in the center of the mass. And if you look carefully, remember those hypoechoic areas that you saw on the echo? Look at the center of this mass. You can actually see a little bit of white there. And that's a little bit of late gad inside the mass. So now what? Contrast echo. I guess not, hey? We don't need that anymore. Cardiac CT, FDG PET, or mass resection. So we're pretty certain that there is a mass there and is most likely a tumor. Should we just refer the patient for resection? Well, there's a little bit, turns out, a little bit more of the story because cardiology got consulted saying, well, what do we do with it? And I actually was on the consult service. So it turns out this lady 12 years ago had a uterine leiomyosarcoma, and she had undergone a hysterectomy. She had multiple lung mets that were resected in 2007. She had palliative chemotherapy for abdominal and pelvic mets resection and radiation of those Mets, multiple recurrences in her abdominal wall. And according to the pathologist, nobody expected her to survive until this time. Now it's 12 years later, and her tumor receptor estrogen positive, and she's on suppressive chemotherapy. So turns out she had been undergoing serial surveillance MRI, and FDG PET. And for those of you who do nuclear, or at least familiar with it, basically is 18 fluorinated deoxyglucose. You take away the OH moiety, you attach fluorine, and it's radioactive. So anything that's metabolically active tends to light up. Now, the interesting thing is the cardiac tissue, being a high consumer of glucose, usually lights up. So if you look at this image, you can see actually that the heart, right in the center there, is lighting up. And you'd expect, okay, if there's a tumor 3 months ago, it should light up, but it didn't light up. Now, so in consultation with oncology, we actually send her for a repeat PET. The interesting difference is that this PET was done without a low carbohydrate diet, and the next PET was done with a low carbohydrate diet prior to the PET. And you can see this time, in the center of the ventricle, there's this mass that basically lights up. So remember, nuclear is all relative, right? So basically, they take the most active, radioactively active image, and they display it. So therefore, the heart in the previous PET scan was lighting up, and the center of it was dark, whereas in this case, the tumor is lighting up, and even though the heart's metabolically active, there's more tumor activity than there is myocardial activity. So after much discussion, the nurse says, well, you know what? I'm going to take my chances. I would actually like to go for a resection because she had beaten the odds for so long, so we sent her to the OR. And this is what the mass looked like in the operating room. Pretty huge mass, measuring, I think it was 5 by 4 centimeters or something like that. And I actually managed to get some pathology slides. This, I'm told, I wouldn't be able to tell this from a kidney, to be honest with you. But, but I guess there are no glomeruli there. But I'm told that this represents classic muscle tissue. The one thing that you can't exactly see here is increased mitotic activity. That would be consistent with malignancy. However, I do have a slide showing the estrogen receptor staining, which turns out brown. So all those nuclei that are, or the cells that are staining brown represent estrogen receptor positive mass. So the conclusion is that the patient actually had a cardiac metastases of a leiomyosarcoma. And when we look back, for those of us who put up our hands saying, you know, primary cardiac tumor versus secondary, turns out that, first of all, cardiac tumors are very rare. And most often, the masses, extra S, pardon me, but that are noted in or on the heart are usually either thrombus or vegetation. And but when we look at primary cardiac tumors, they're exceedingly rare in comparison to secondary tumors, but the majority are benign, and most commonly are myxoma. Of the malignant tumors, the majority are sarcomas, and the overall survival is quite poor, 17% 5-year survival. And so when we go back to the complementary role of imaging, from an academic standpoint, it would have been interesting to look at contrast with perfusion, but I didn't feel like I could justify. It's $120, and if we're going to do an MRI to characterize the tissue and look at whether or not the mass is adherent to the cardiac muscle to plan for surgery, we decided not to go for it. The echo, on the other hand, does help us clarify the location, the appearance, the size, and the mobility of the mass. The MRI gives us information on perfusion. Typically, thrombi do not have perfusion, and depending upon the contrast setting that you use, occasionally you will see both anterior and posterior and surrounding the mass, making it look like there's perfusion when actually there's not. Late gadolinium enhancement gives you information regarding necrosis. And then FDG PET will tell you about metabolic activity. So I'm keeping it short here. I want to open up for any discussion. I do want to acknowledge 3 of my colleagues who helped me. One is a resident that I saw the case with, and the other 2 pathologists that helped provide those slides. Thank you.
Thank you, Jonathan. I think it does highlight, although it's a very rare case, it does highlight the importance of complementary imaging in contemporary